is coming. Hello, everyone. Welcome to our Zoom meeting. Today, we'll have a couple of items in the agenda. The Lime team will be presenting, but before we start, I'd like to welcome Dr. Chowdhury, and he matched, and he would like to share some of his perspective or tips with you guys. Welcome back. Go ahead.
Hi, thank you so much, Dr. Nadir, and to all of the fellows that are here. Just wanted to, give a thanks, to everyone for, this past entire match cycle. I really feel like, some of the things that we did here together made a big difference for me, and the mentorship that I had and the experiences that I was able to hear about everyone. And really, I feel made a huge difference for me in my match process. And there's a lot of things that I learned, throughout the match process. I'm just to give you guys like a little bit of a background. First, let me see if I could share this. Would it be all right if I shared my screen?
Yes, please.
Okay. Let me see if I could share my whole window. Okay. Just give me 1 second because um, okay, I'm sorry. I just had to give Zoom access to be able to see my screen. I apologize.
No worries, no worries.
So I have to quit and I have to come back in order to be able to do that. Everyone can just wait for a moment. I'm going to close the app and I'll rejoin. Okay.
Sounds good. Thank you.
Thank you. Sorry for the delay, everyone.
And no worries.
Thank you.
So I think there was another senior of the, or one fellow who matched it also would like to share some of the tips. Do we have one available here, or maybe for next week? That's all right. So we will wait for Dr. Chowdhury to join again. I'm going to share his contact info just in case you want to get in touch with him. So I'm going to share his email address.
Okay, everyone, I'm back. I apologize. All right, here we go. Now I think I'll be able to share my, yes. So here it is. I think everyone can see my screen here in the background, right?
Yes, we can.
Okay, perfect. So what I'm going to do now is I'm just going to try to maximize this screen over here so everyone see the presentation behind the screen, correct? Okay. So
Yeah.
just wanted to start off talking about give you a little bit about myself. I wanted to first start off just telling you guys a little bit about myself. I'm a Caribbean medical school graduate. I graduated in 2019. So obviously, I have a few years, of a gap, between now and the time that I applied to residency. There was a lot of things that, I heard throughout the process that, I was too old of a graduate, and, I didn't have, enough clinical work, or I didn't have enough stuff on my CV. There's a lot of things that I heard from a lot of people. And so, I just kind of wanted to start off by trying to get that point across that, we all have deficiencies, in our CV, in our professional careers. But just wanted to reiterate the fact that that nothing is impossible. That anything that you truly want to do, you absolutely can. And I am an example of that. Because once upon a time, about a year ago, if you had asked me, do you think if I thought I would match, I would absolutely tell you I don't know if I have any chance. But just to give you a little bit of a background, in June of 2023, my father had passed away tragically. He had fell off a ladder and he hit his head, and he had a subarachnoid hemorrhage and then expired shortly at the hospital. I went into a full-on like fight or flight mode at this moment. I wanted to not only do it for my father but also do it for myself, because now I was the eldest and the man of my household. So I had put my focus together and I'd taken my steps. I took step one, I took step two, CK. I went through all of the processes. I did the clinical stuff. Like they wanted to see me do clinical experience. I went to another place with one of my doctors that I knew, and he gave me a little bit of work where I could get some clinical experience and put down in my CV. Basically, I did everything that I needed to do in a short time. In a short time period. We're talking about in June of 2023 is when this accident had happened. Up until that point, I really was not progressing in any positive direction. But what I've tried to explain is that like how quickly things can change and how quickly, you can make a difference, in redirecting the, trajectory of your life and your chances of matching. I took step one, I took step two. I had applied into residency. And another thing, is that like I had a crazy, crazy experience because I applied in November. Which everyone may know is very late into the match cycle. And then somehow, I still ended up with 8 interviews. And I ended up matching into internal medicine. And just for so everyone understands, I'm not allowed to mention the name of my residency program specifically because the residency program has like given us certain restrictions and rules as far as like, doing anything that's affiliated with them. So that's why I'm talking to you here as just, as somebody that was a part of this research fellowship, somebody that is just looking to help people out who may be in a similar situation that I was in a few years ago, and to help guide them through the process, because I had a wild ride and it was a wild, experience, getting from there to getting to where I am right now. So that's just a little bit of a, preview into my background, my experience and my journey. So just the first thing that I kind of, and any questions, if anyone has any questions, please, you can just let me know, okay? Just to give you a little bit about the timeline, and this is really important. So anybody that is planning to apply this cycle, the EROS tokens, I believe, are going to be available here very soon. So I believe it's going to be on the end of the month, if I'm not mistaken. But whenever the EROS token is available, the first thing you should do if you do plan on applying in this match cycle is purchasing an EROS token. That's number one. Sorry, I'm just checking the chat and okay. 25th. Yes. So yeah, so we have some people over here that know what it is. Okay, so that's really good. Yeah, so you have to make sure that yeah, so just keep in mind of the entire timeline. So you start off with the EROS token. When you have the EROS token, there's going to be a whole process into setting up a EROS account, EROS profile. So just make sure that you're going ahead and you're doing all of that. Another important thing that I really kind of try to tell people about is that this ECFMG certification has become incredibly, incredibly difficult and inconvenient, is the best way to describe it. And the best way that I can explain this is if you are a graduate after January 1st, 2023, meaning if your date of graduation is before January 1st, 2023, you have to do something called mini CEX cases, right? This is a pathway number 6. So there's multiple different pathways that will basically verify your clinical skills component of your ECFMG certification, because as we know, step 1, step 2 are 2 components. Another component of the ECFMG certification is this clinical skills component. Once upon a time, people used to take a step 2 CS exam for that. That is no longer the case since the pandemic. That has been discontinued. So you have to apply for a certain pathway to get the clinical skills component satisfied in order to get the ECFMG certification. So for people who have graduated before January 1st, 2023, and for me, that was the case, obviously. You have to do something called mini CEX cases. I put a link over here in this next slide, if everyone can see the next slide over here. It's saying you just have to copy paste this link and you'll be able to go in and learn more about it. But the reason why I tell you about this is because it is very complicated. What you basically have to do is you have to do 6 clinical encounters. You have to get a physician to go into their portal, make an account, and do 6 clinical encounters with you. You can only do a maximum of 2 clinical encounters per physician. So what that means is that you have to find 3 different doctors to do a mock clinical case with you, like a OSCE. And you will see the patient and they will score you based on a criteria that the ECFMG gives them. It's like a piece of paper that judges you on professionalism, your history taking, your physical exam, all of these things. So it's pretty, it's pretty complicated. And there's requirements and criteria for which physicians can do this too. So you have to do 6 cases. Each physician is only able to a maximum of 2, right? So you have to find 3 people and do 2 cases with each person. And the physician has to be in practice for a minimum of 5 years. So it can't be a brand new physician either. It has to be somebody that has been in practice for 5 years. Now, I read online that it doesn't have to be a US physician. Like, for example, you can use a physician in your network, maybe somebody that you know, as long as they are a physician and they've been in practice for 5 years, then you'll be able to satisfy the criteria for the mini CEX. But I just mentioned this just so that you know ahead of time, this was a very, very complicated process for me, right? That I had to do, and it took me forever to do it. Another thing is the OET. Okay, I didn't write it down in this presentation, but as I'm talking about this, I just remembered the OET also. Get it done ahead of time, because if you don't get the OET done by January, even if you match, let's say a program takes you. If you don't have OET by January, a past OET by January, you will not get ECFMG certification. Then that program will have to forfeit you. So please just make sure that you have the ECFMG certification, that you do the OET exam, and that you try to get ahead of it early. Okay. Yeah. So that's just a thing. And then another thing is that certain schools, like my school, for example, there's something called MSPE. Okay. This is your medical school's performance and evaluation of you as a graduate, as a student. Every applicant has to submit a MSPE. Okay. So just make sure, again, that's, I don't know if that's written over here. So yeah, it's not, but like you have to make sure that you submit, your school submits, here it is on the bottom. You will not be able to submit MSPE. So you have to make sure that you submit it, your medical school submits an MSPE. For some people, their medical school does the whole thing for them. For others, you may have to go to your school and specifically request them to upload one on your behalf. So just another thing. So 3 things that I talked about here, okay, as far as the ECFMG certification, okay, make sure. Sorry.
Sorry about that.
Oh, yeah, no worries. Okay. So yeah, so just make sure that you get ahead of that. Okay. So the ECFMG certification, for that, you're going to have step 1 and step 2. You're going to have to do OET, and you're also going to have to do, if you are a graduate before January 1st, 2023, you're going to have to do pathway 6. So you're going to have to get 6 mini CEX cases. Once all of this is done, then you will be getting the ECFMG certification. Okay. So it takes a long time, and just try to make sure that, you get ahead of it if you are planning to apply on this cycle. Okay. Now, moving forward, the next thing that I wanted to talk about here is that, like, if you're somebody right now who has taken step 1 already and you're studying for step 2 CK, what I would try to tell you is try to take it, because right now we're in June. And like I said, I took my exam in November. and I applied at the end of November, and I was able to match. So, and there's a trick on how you can get interviews, and I'm going to go over that with you guys next, right? But what I try to emphasize to you is that, like, imagine the repercussions of you waiting an entire year more. You don't want to do that. If you have a chance to take CK now and try to get an application in, why wouldn't you? I have heard numerous stories about people who apply in November. I have one friend that applied in January, right before SOAP started. He didn't even apply to any programs. He just applied simply to get into SOAP. He paid like whatever that amount is, $40 for the SOAP. That's all he paid his entire match cycle. And then obviously for the ERAS token, all of those fees, but he paid very little. He didn't spend thousands. All he did was just get in time for SOAP, and then he matched through SOAP. So there are numerous stories of people that are able to do it off cycle. Do not sell yourself short. Obviously, it's best to apply on time. You will be maximizing your chances if you apply on time. But what I'm saying is that if you already have step 1 done, from right now until the end of August, and if not August, definitely by the end of the year, there's enough time for you to be able to take your step 2 CK. Just to give you some general, very high yield advice for how you should study for step 2 CK. You want to do it system-wise, okay? You want to do it system-wise, 80 to 100 questions every single day, 5 to 6 days a week. You can take one day off. And let me just tell you guys this. If you're having an off day and you don't feel like doing anything, right? Let's say you're supposed to do your 80 questions today, you're not doing anything. Listen, just do 20. Just do 20. And something that helped me, I had a study partner, somebody that I would get online with every single day, and we would just do 20 questions together. I would answer 10, she would answer 10. And that's how we would finish our 20. And then somehow during the day, I would do another 40 by myself, 40 to 60 by myself. That's how I was hitting my target of 80. Another thing, when we are doing questions, sometimes we feel like we want to write everything down. We want to write everything. Oh, we have to understand, we have to memorize. No, you don't have to memorize everything. Keep it simple, okay? When you do a block, finish the block, and let's say you're so lazy and you know this about yourself, don't look at your flags. Don't even look at your correct answer choices. Only look at your incorrects. So for example, if you do a block of 40 and you got 50% on it, that's 20 questions. Don't even look at the other 20. Just look at the 20 that you got wrong, move on to the next block. You have to hit your target. You have to hit that 80 per day. This is what's going to help you the most. And then the way that I would go about it, some people like to do Anki, some people like to write it down on a piece of paper. The way that I would recommend is that when you get a question wrong, first read it. Read what you got wrong, why you got it wrong, and then in one line, you're going to write down, this is where my thought process went wrong. And then you're going to write down in another line, this is the correct answer, and this is why. That's it. And you're going to have a bunch of these like 1 or 2 liners that's going to summarize the entire question. That's going to summarize the entire explanation. And then you're going to move on to the next one. So I'm just trying to explain that, and it's hard. What I'm telling you is hard. I myself have had a lot of difficulty just moving on. But I am trying to get this across to you that you have to move on. You have to get through the questions. And the biggest reason why we don't is because we spend way too long on just 1 or 2. And then we don't have the motivation to get through the rest. Pace yourself. Keep it simple. And just do the bare minimum and move on. If you don't feel like writing notes, just read it. If you don't feel like doing anything, just do it. You know what I mean? Like, this is what I'm trying to explain to you guys, that be honest with yourself and try to keep it as simple as possible, but you have to hit that 80 to 100 a day. The next thing is that once you are getting through UWorld, each week or every 2 weeks, you want to do an NBME assessment. And I recommend you do them online. I know it costs some money. It costs about $60 to do it online. But the benefit is that they give you a score report and they tell you what your strengths and your weaknesses are. And this is great because you can look at your weaknesses and you can target 2 systems. And for the rest of the week after that, the next 2 weeks after that, before you take your next attempt, you can specifically target those systems. And so it's just a great way. By the time you get through 3, 4 assessments, you're basically going to hit all of your weak areas. You're guaranteed to pass at this point. You're guaranteed to get through the exam. CMS forms, the Amboss High Yield 200, Amboss High Yield question sets, all of these are tools that you have at your disposal, and to be completely honest with you, if you have passed step 1, you don't need more than 3 months to take step 2 CK. You don't need more than 3 months. But if you would like to, you can take up to 6. And as you guys may know, the minimum score for step 2 CK has gone up again from 214 up to 218 now, which is insane because once upon a time, I know people that are in fellowships right now with 220, you know what I mean, on their CK, and to know and to even consider the fact that now this is just 2 points above the passing minimum. Make sure you get a 240 or higher. Make sure that your score is going to be above 240. So again, I've linked my contact information, my email. I created a little Instagram as well that's not affiliated with my hospital, so they can't like really, say that I did anything under their name. So if anybody would like to communicate with me or talk to me about how they want to study, I'm not going to charge anybody anything. Again, I'm not allowed to get any monetary gain, for anything that I do while I'm under the jurisdiction of my hospital. So I'm literally just here as your mentor, and to help you guys out and to get you through this process. This is the worst phase, to be in, this process of trying to match, waiting every single year as our life passes by us. And so, I know what that's like, and I really want to help everybody else get to that point. Okay. So now I want to talk about the application itself. Okay. Letters of recommendation. We're going to split that into 3 sections. Okay. It's going to be letters of recommendation, personal statements, and then the general structure of your application. Okay. So the first thing that I want to talk about is the LORs. Okay. The LORs, right? It's kind of tricky how people want to go about it. You do need to have, US doctors write this down for you. I know this is a little bit of a challenge for some people that are not in the United States. I'm looking into something that might help you guys at this moment, though. Obviously, you probably know the appropriate channels on how to obtain the letters of recommendation. What you need to do is just make sure that one of your letters, right, is somewhat recent. You don't want it to be a letter from a doctor that you worked with 5 years ago. You know what I mean? You want one of your letters to be somebody that worked with you very recently. And by that, I mean probably within the last 1 or 2 years. And the next thing that I want to say is that there's a little thing, right, about general letters and specialty specific letters. And what I mean by this, right, is that let's say you find 3 doctors that are willing to write letters for you, okay? Let's say you're going to be applying for internal medicine, family medicine, and psychiatry, like I did, okay? What I did, right, I had 3 doctors write me letters. The internal medicine doctor wrote me a specific letter for IM. The family medicine doctor wrote me a specific letter for FM. And the psychiatry doctor wrote me a specific letter for psychiatry. What they also did is they wrote me a general letter that I could use for any specialty. So what I mean by that is, let's say they write their LOR for me, the whole entire thing. The last line of the LOR should be, if it's a specialty specific, so for example, the psychiatrist wrote down, I would recommend Dr. Farjahan for this psychiatry residency. Specifically, we would write down this psychiatry residency. On another letter, and so you would have to submit 2 letter requests. Through EROS, you have to submit 2 letter requests to the physician so that they do this. And it's not hard for them because all they have to do is change 1 line at the end of the letter. For the psychiatry specific letter, it was, I recommend Farjahan for this psychiatry residency. And then he would also write down, I recommend Farjahan for any residency program. So what happens is that one of the letters, I'm able to use it for psychiatry specifically. The other letter, I can use it as a as a letter for IM. I could use it as a letter for FM. I could use it as a letter for any other specialty. Does that make sense to everybody? So all you have to do is just tell the doctor to change the final line of your letter. And then this allows you to be able to use multiple letters interchangeably. So that's basically what I did. I had one letter that was specific for IM, one specific for FM, and one specific for psych. And then what I was able to do is I added the specific letter for each one. So that's one letter. And then I added two general letters. For psychiatry, my FM and IM doctor that I wrote down, I recommend Farjahan for any residency program. I added those for psychiatry. That was my 3. Same thing for FM. I had my 3. Same thing for IM. I had my 3. So I hope I was able to explain that, properly to everybody. But basically, you want to try to utilize that. It's like a sneaky way of not having to get too many doctors, involved. You can just get the, doctors that you need, be able to, so that you're able to not bother too many people and use the 3 doctors or whatever that you have to get through as many applications as you possibly can. Any questions? No. Okay. All right. Let me see.
Hello, I have a question, please.
Yeah. Mm-hmm.
What do you think the most important thing you did it to make it easy for you to match? Is it the whole things, or you have like specific thing you did it? You advise us to do it.
Yeah. So sure. To make it simple, you're right. I think if anyone has specific questions about, when the time comes, how to do the LOR, how to do your personal statements, how to make the general structure of your application, let me know. I guess to keep it simple, right? The biggest trick that I had, and this is the trick for me, this was the main thing that I really kind of wanted to share with everyone. This was the trick that I feel it was a game changer for me, is to apply to the newly accredited programs. I think a lot of people don't know about this, but this link over here, right? You could just search it up online. You can go to ACGME, newly accredited program list, right? If you just go to that and you just search whichever specialty you're interested in. Let's say it's IM, let's say it's FM, let's say it's psych, ED, whatever it may be, emergency, whatever it may be, a list will come up of programs that were accredited within the recent year, or programs that were accredited within the last 2 years. And so I think that it's beneficial for you to apply to these programs because they are brand new programs. So they're not as strict, with certain rules like year of graduation or number of attempts or scores, you know what I mean? Because they're trying to fill their spots too. They are just getting off the floor themselves, So you have a really good shot, at getting interviews if you apply to these programs. This is the biggest takeaway, the biggest trick that I found gave me, like I said, I applied at the end of November and I ended up with 8 interviews still. And my peers, my friends, they were shocked. They were shocked at how this was happening for me because they thought I wasn't going to land a single interview. I mean, out of worry for me, not because, obviously they wished the best for me, but they were worried for me. But this was a trick that I did that I feel made the biggest difference for me. And so, utilize this. When it's time for the match, go to the ACGME newly accredited program list. Obviously, I put the link over there, but just remember that ACGME newly accredited program list, and you will be able to find all of the new programs for whichever subspecialty that you're trying to apply to. Another thing is that each year, what I'm realizing is that if your ultimate goal is to just match, and it doesn't matter about your specialty, from what I hear, pediatrics is unfilled almost every single year. So build a CV for pediatrics. You know what I mean? Build a CV for pediatrics and see if you can get into a pediatric residency in the United States. I believe, it's one of those fields that is projected to have a huge shortage, in the future. So if you apply to those programs, and again, because it's already a program, a type of specialty that is in need of doctors, And then on top of that, if it's also a newly accredited program, I think you have a really, really good shot of getting interviews. You know what I mean? So that's basically like what I would recommend. This was the number one like thing that I really wanted to let everybody know about. The next thing here is that I kind of just wanted to talk about the general structure of the application. And for that, I was going to go through my application and just show you what I did. But just to talk about like, how I would go about structuring the application. There's a section called honors and awards, right? And so people only put down like actual honors and actual awards, that they got. But, yeah, yeah. Yeah, and so basically like, what you can do, right? And what I did, for example, and if I just find my let me see. So as you guys can probably see, right, is that for honors and awards, right, there's a section, there's a way that everyone can see my screen, right?
Yes.
Okay. So for the honors and awards, right, you can see like people just stop there. You know what I mean? But look at what I did, for example. You're allowed to add, you can put the word other, right? And you can add things in there. So for example, like when I was in high school, I was a top 100 runner. Maybe you're an athlete. Maybe there's something about you that's really, really unique. You know what I mean? Put that down. Uh, Maybe you got an award for a subject. Put that down. Uh, I know a lot of residency programs like people who can present because you have to do didactics, you have to teach. They like to see peer mentors. So I wrote down that I had an award for best presentation skills. These are just like little things, right? That I believe, right, make a difference and really kind of make somebody interested in learning more about you. Going a little bit further, right? The way that I recommend doing your experiences, right? And this is the way that I recommend it is right over here. You want to have 2 to 3 experiences related to clinical stuff. Okay. You want to have 1 to 2 experiences related to community outreach. You want to have 1 to 2 experiences showing you have organizational skills, 1 to 2 experiences showing you have leadership/mentorship skills. And then you also want to show something for research. So for example, on my CV, I wrote about this geriatric research fellowship as a part of my research component. I wrote that I was a teacher assistant when I was in medical school to show that, I know how to teach my peers. When it came to organizational skills, I talked about a health community fair event that I did where we basically set up health assessments outside of a busy supermarket. And so, people from the community were able to come by and we were able to give them free healthcare assessments for that. And then I told them that I played a leading role in organizing the event. So they like to see that. They like to see that you have organizational skills. They like to see that you are showing the ability to lead, you are showing the ability to teach, and they obviously like to see that you are doing research, that you are interested in doing research. And then you need to also show clinical experiences. I had clinical experiences as well, but that's obvious. You're going to have clinical experiences. These other things, I really do believe, make a difference. So first thing I put down is my clinical experience. Then I put down, my father was the founder of a orphanage in my home country, and there's a medical clinic on the second floor. So, this is great, like something that I talked about here, that I think they probably really like, because a lot of the new residency programs, they open the residency programs because there's a lack of healthcare access in these areas. So when you're talking about things like this, like what I wrote down here is that in this village, there wasn't any hospital or medical clinic for a 25-mile radius. These are the type of things that you kind of want to talk about to be able to get their attention, and for them to understand that you are interested in, maybe doing community outreach or helping a healthcare in a place where it is needed the most, such as a place that has a huge disparity when it comes to physician shortage, for example. And then, so then I wrote about the geriatric research fellowship. And then the rest of it was all, basically like my clinical experiences. And then I wrote teaching assistant and lead organizer, so just to that's what I'm trying to say is that when you're structuring your CV, you want it to be well-rounded in this regard. You know what I mean? So in my CV, I was basically indirectly able to say that, hey, I'm an athlete, okay? I am a teacher. I am a really good presenter. I love to do community service. I'm a leader, you know. I also like to teach and mentor my peers. And at the same time, I'm also a physician. So it's like you being able to put all of those together and you do it in your way, the way that you think you can get that across for yourself the best, you do it in your way. And this, I think, genuinely, I believe that together, I feel that this made a huge difference, for me, in regards to how I matched and the number of interviews that I got and the experience that I had throughout the residency match process. So yeah, basically, guys, like, that's and then a final point for everyone, okay? Do not use artificial intelligence for your personal statements. Don't do it, okay? Please don't do it. They have softwares. They're going to know you're going to get filtered out immediately. Do not use ChatGPT. You can use ChatGPT to give you suggestions, but do not use it, because if you do, you're literally going to get flagged and your whole application is going to get tossed into the trash, okay? So just trying to see if there's anything else. Okay, yeah. And then the final thing is that when you do get interviews, because I know a lot of people that get interviews, but then I think they perform very poorly in the interviews itself. So if you are somebody that gets an interview and, for example, like, you are kind of nervous and you don't know exactly how to do it, reach out to me. I linked my email and my Instagram profile on the next page. Just reach out to me and we can do a mock interview together. Obviously, we're both going to be busy, but I'll work out a time where I can fit you into my schedule and we'll do a couple of mock interviews together so you feel a little bit more ready. But outside of that, like, it doesn't even have to be me. Like, get your brother or get your sister or get your husband or your wife, or for me, it was my little brother. Like, you can get anybody, give them a list of questions and just keep doing it over and over again. Do mock interviews every single day. And over time, you're going to get really good at it. But again, yes, this is an option for everyone as well. You guys can reach out to me and we'll do mock interviews. And obviously, like, I'm not charging you guys anything. You just let me know and I'm completely willing to help you out. Yeah, and so this is my contact information. If anybody, what is it called, wants to get in touch with me or add me on Instagram, let me know, and we'll be in touch. Final key points. Number one, make sure that you are ahead of the game and that you get your EROS token, that you get your ECFMG certification, you take your OET, the mini CEX cases, you request the MSPE from your medical school. Make sure that you do all of that and get ahead of the whole process. EROS and NRMP are two separate entities. When you sign up for EROS, eventually you're going to have to also sign up for NRMP. So that's that, first thing. Secondly is that when you're structuring your CV, make sure that it is very well-rounded, where it shows your leadership capabilities, it shows your organizational skills, it shows your willingness to teach, it shows your willingness to help the community, it shows your willingness to do research. It also, on top of that, also shows that you are an astute clinician as well. So together, this embodies what a residency program is going to be looking for. Okay. And then the final point is that, take your exam and try to get over a 240. The biggest takeaway, the biggest trick, the hack of the whole system is that newly accredited ACGME list. I'm telling you guys, and then trying to apply into specialties that have a shortage, like pediatrics, family medicine, you know what I mean? I think that there are open spots every year. So trying to apply it into those and getting into those, it's a safe bet and you have a good shot. So yeah, just a little cheesy quote to finish it off. The difference between ordinary and extraordinary is that little extra. So yeah. All right. That's it for me. Is there any questions? Anybody have any questions?
Hello, doctor. I actually wanted to ask regarding the lawyers. Like for each application you choose to submit which lawyer? Like, is it an option or all of them just come in the ARS application?
So the way that it works, right? And that's a good question because it was very confusing for me as well. You have to submit LOR requests to the doctors, right? From ERAS. You have to make ERAS profile. You have to submit LOR requests from ERAS. After they upload the letter, right? Then you're going to have like a section in ERAS where you press on LORs and all of your uploaded letters are going to be there. When you are applying to programs, you're going to assign the letters to those programs. And so there's an easier way to do it in the interface when you can go online and you can pick and choose which one you want where. So it would be good for you to title the LOR in such a way that you can keep track of which one is which. So for example, for me, I put down psychiatry letter and then I wrote down psychiatry general. So I knew which one was my psychiatry specific letter and which one was the general letter that I was just attaching to every other application. So yes, you will get to, there's going to be a way for you to pick and choose which letter you want to assign to which program, depending on specialty and your preferences.
Okay, thank you, doc.
Sure. And feel free to reach out to me. Like I said, when the time comes around, it is confusing. It took me almost like 4 months for me to realize that I didn't have to press one at a time. Every program that I applied to, I assigned my letters to them one at a time. So you can imagine 150 applications, almost how long it took me hours to assign each one. There's a way to just assign the letter to everything. So it's like I had such a waste of time throughout the process. Like when you guys are going through it, please feel free to reach out and I'll try to help out in the best way that I possibly can.
Really appreciate your support. Thank you so much.
Yeah, for sure. Guys, best of luck, with your with your with your exams and with everything. Like, I honestly, like, I know that it was a very difficult process, getting into residency and all of that. Like it was the most like grueling process. And so I'm here for you, and I just wanted everyone to know that, like I said, I was my peers, my friends, they've forgotten about me at some point. They were just like, they always believed in me, but at some point they were like, okay, I don't know if this guy can do it anymore. You know what I mean? And rightfully so, because so many years went by since I graduated. And then all of a sudden it's like, I rose back, from the dead and I was able to make it. And so that's why I say that. I always tell people, I'm like, guys, if I was able to do it, everybody can, and so that's why, like, don't sell yourself short, don't put yourself down, believe in yourself. And, I believe in all of you. Best of luck to everybody, throughout the residency match cycle and in your personal and professional endeavors. And if you need anything at all, you can contact me.
Thank you so much, Dr. Farjan, for these great tips and sharing your experience. And I'm very sorry for your loss as well.
Thank you. Thank you, Dr. Nadir. I really appreciate everything that you're doing for us. Thank you. I'm sorry I took a lot of time, everyone. I apologize. Thank you.
This is very, very helpful, I think, for everyone.
Thank you.
If
Thank
you
you,
have any
everyone.
questions, please reach out to Dr. Farjan Chowdhury. He has a contact information. And thank you once again, and we wish you all the best and good luck with your program, and keep us posted, and good luck.
Thank you. Thank you, everyone. I just put my email into the group chat. If you want to get in contact with me, just put down research fellow at the subject, and I'll be there for you in whichever way I can. Thank you, everyone. Thank you so much for your time.
Thank you. Have a wonderful one.
You too.
So Dr. Saudat and her team will be presenting the rest of the topics for today's meeting.
Hello, good evening, everyone. Thank you all for joining us today for this exciting session. We have a fantastic lineup of presentations covering key topics. My name is Saudat Asim, and I'll be your moderator today. Our first session is on polypharmacy in older adults, a critical topic as medication management becomes increasingly complex with age. Please join me in welcoming our presenter, Dr. Marian from Team Magneta 2. Dr. Marian, are you here?
Hello, can you hear
Yes,
me?
hello, Dr. Marian, the floor is yours.
Hello, Dr. Sadad. Hello, Dr. Nader. Thank you for this great opportunity, and hello, everybody. I'm gonna start sharing the screen now. Can you all see the screen, my screen?
Yes, we can.
Okay. So our topic today is about polypharmacy in adults. It's an important topic because, as Dr. Sadad mentioned, there are a lot of challenges with the many medications that patients have. So we're going to start with the definition of polypharmacy. So polypharmacy is defined as using multiple prescription drugs, usually when it's more than 5 medications. It increases the risk of numerous negative health consequences in the elderly. Regarding the prevalence of polypharmacy, when we look at the diagram here, we can see that the highest rate is in the US, especially among patients older than 65 years old, with a rate of 65%, followed by India with a rate of 49%, and then South Korea 42%, followed by Australia 36%, and finally with Europe 26 to 40%. So why do medication work differently in older adults? And there are increased risk of side effects with age, and this is because there are a lot of physiological changes that impact our body systems when we age. The first thing is, as we can see, like there is decline of liver's first pass metabolism. So when we start to prescribe medications that are metabolized through the liver first pass metabolism, we have to lower the dosages in older adults. Also, there is decrease in renal function because most elderly people usually develop chronic kidney disease with aging because the kidneys get atrophied and the renal blood flow decreased by half at like when people age more than 65-year-old. Also, there is a change in body composition. And when the body composition change, like the ratio of lean body weight to body fat decreases, this change also the distribution of drugs throughout the body. And the last but not least, there is reduced serum protein levels in our body. Levels of serum protein, which binds many drug, decreases in malnutrition and dietary changes. And this can happen for different reasons in old people. Sometimes it's for lifestyle changes like diet, and others are for unintentional reasons like dentures, altered appetites, a change restriction in food. We have some risk factors for polypharmacy. Some of them are patient-related risk factors and others are health system-related risk factors. So the patient-related risk factors include like older adults, like more than 62-year-old. If a patient has a cognitive impairment or developmental disabilities, frailty is another reason, lack of primary care physicians, patients with mental health conditions, and patients with chronic comorbidities and multiple diseases, residing in a long-term care facility, seeing many subspecialties, and also self-medication with over-the-counter drugs and herbal use. Sorry. So when we talk about the health system-related risk factors, we talk about poor medical records keeping, poor transition of care, especially like when we discharge patients from the hospital and they miss their follow-up with their primary care physician. And the last one is automated refill system use. So what are the consequences of polypharmacy and why they are risky? So sometimes we have interactions between drugs and disease, like for example, patient with chronic kidney disease, their condition deteriorates when they use like non-steroidal anti-inflammatory drug as medication like ibuprofen. Also, there are some adverse drug reactions like peptic ulcers, kidney damage, hepatic damage. A study has demonstrated that outpatients, when they take more than 5 or more medications, there is increased risk by 88% of adverse drug outcomes compared to those who were taking fewer medications. Also, some medications, they cause sedation, and this over-sedation can happen with over-the-counter antihistamines and opiates. And this can lead to loss of balance and increased risk of falls. And also, there is increased risk of delirium in patients with cognitive impairment. Polypharmacy can lead to medication non-adherence because patients can get confused about which medication they should take, and usually they forget, especially if they, as we mentioned before, if they have cognitive impairment. There is roughly 30% increase in medical expenses as a result of a higher risk of hospitalization and outpatient visits. In this slide, we're going to talk about some examples of drug combinations known adverse reactions. The first one is ACE inhibitors and potassium-sparing diuretics, like lisinopril when it's combined with spironolactone. The most common adverse effect for this combination is severe hyperkalemia, especially among patients with chronic kidney disease, older adults, and high potassium intake. So how to protect patients against this adverse reaction? It's first of all, we should monitor serum potassium and creatinine regularly, avoid potassium supplements unless it's necessary, and we should consider using a thiazide diuretics instead of potassium-sparing diuretic. Another example is SSRIs plus non-steroidal anti-inflammatory drugs like sertraline and ibuprofen. They both increase risk of GI bleeding. The SSRIs usually impair the platelet aggregation, while the non-steroidal anti-inflammatory drugs, they damage the gastric mucosa. So to protect patient, we can co-prescribe a proton pump inhibitor like omeprazole and use the lowest effective non-steroidal anti-inflammatory drug dose for shortest duration. And if it's possible and effective, we can consider changing the non-steroidal anti-inflammatory drug to acetaminophen as an alternative for pain. Another example is macrolide antibiotics and statins like clarithromycin and simvastatin. The adverse effect is rhabdomyolysis, and this happens usually due to the inhibition of CYP3A4. And we can protect patients by, like, if the patient has to take this antibiotic, like the clarithromycin, we can hold the statin during the antibiotic course if the patient condition allows us to do so. And we can use a different antibiotic that is non-interacting, like azithromycin, or we can change the statins to another less medication that is less metabolized by the CYP3A4 pathway, like pravastatin. Also, we have the loop diuretics interaction with the aminoglycosides like furosemide and gentamicin. And the adverse effect that happen is ototoxicity and nephrotoxicity. So to protect against this side effect, we can avoid the combination unless absolutely necessary. And we can usually monitor renal function and hearing regularly and use shortest effective duration and adjust doses based on the renal function. The last one we have is the combination of antiplatelets and anticoagulants like aspirin and warfarin. The common side effect here is major bleeding. To protect against major bleeding, we should use this combination only when a strong indication exists, like if we have a patient with chronic artery disease and also a mechanical valve. And we can regularly and monitor the INR and educate the patient on bleeding signs and fall precautions. So next, we're going to talk about how we can clinically do an assessment for polypharmacy. So the first thing is to do medical reconciliation at least once a year and after any visit, fall or hospitalization or emergency department visit. And we can use tools like the Beers criteria and stop/start. And the last one is the rule of pharmacist and the interdisciplinary teams. First, we're going to talk about the 5 Beers criteria. So the American Geriatric Society uses specific criteria to list potentially inappropriate medication for adults over age 65. We have 5 sections of the Beers criteria. The first, medications that they recommend to avoid if patients over 65 years old and not in a hospice or palliative care setting. The second one is medications to avoid among people with certain health conditions. And then medications to avoid that can cause drug interactions when combined with other medications like the ones we talked about before. Medications to avoid due to harmful side effects that outweigh the benefits, and medications to use at limited doses or avoided due to their effects on kidney function like renal impairment. So now we're going to discuss the last 2023 American Geriatric Society Beers criteria for potentially inappropriate medication used in older adults. So the first drug that they usually recommend to be cautious or avoid it is the first generation antihistamines, because we should avoid them in older adults in general because they can cause sedation, confusion, and dry mouth due to strong anticholinergic effects. The second one is nitrofurantoin, which is an antibiotic. We use it for patients with urinary tract infection. We should avoid or be cautious with this medication in adults with significantly reduced kidney function, especially if their creatinine clearance is less than 30 milliliter per minute, because in this case, there is limited effectiveness and increased risk of toxicity and impaired renal clearance. Also, aspirin is usually not used for primary prevention, especially in adults more than 70 years old, because there is marginal benefit and there is increased risk of bleeding that outweighs preventive value. Non-steroidal anti-inflammatory drugs, like adults with heart failure and chronic kidney disease or GI risk, because they are usually associated with fluid retention, kidney injury, and high risk of gastrointestinal bleeding. Another medication is benzodiazepine, especially in adults with dementia, history of falls, or delirium, because they usually worsen the cognitive impairment and increase the fall risk. Similar to the third generation antihistamines, like the anticholinergic agents like oxybutynin, we should avoid it in adults with cognitive impairment or frailty because they contribute to confusion, dry mouth, constipation, and increased fall risk as well. Amiodarone, we should be cautious when we use it in older adult patients with atrial fibrillation without heart failure, because the long-term use linked to thyroid toxicity, lung and liver diseases as well. Gabapentin and enoxaparin and direct oral anticoagulants should be avoided in adults with renal impairment. And if we have to use it, it requires dose adjustment to prevent the accumulation and adverse effects of this medication. The last one is the tricyclic antidepressants, especially in older adults with cognitive issues or balance concerns, and because it can cause orthostatic hypotension, dizziness, and worsening confusion. So Beers criteria has some potential risks, and this is because it's not a person specific or individualized for each patient. The Beers criteria doesn't take into consideration a person's general health, all underlying medical conditions or circumstances that may lead to a healthcare provider to choose a specific medication. Because of this, Beers criteria is a tool that can help providers, but it's not something that makes decisions on behalf of a skilled, experienced healthcare provider, because each patient requires a tailored treatment plan based on their general health. The other assessment tool is the stop and the start criteria, and they usually are used together to identify medications that may be inappropriate using stop criteria or alternative medications that can be started safely to treat a disease like start criteria. Both help reduce the medication's adverse events and the drug interactions. How can we manage polypharmacy? So the goal in general is to optimize medications used to improve outcomes, reduce harm, and align with the patient-centered care. The first thing is comprehensive medication review and reconciliation, focusing on a patient education. Like we can use open-ended questions or teach back to assess the patient and caregiver understanding of the indication, compliance, the drug's benefits and adverse effects. A multidisciplinary team of physicians, pharmacists, nurses, physical therapy team should cooperate to manage the patient's condition. And deprescribing is a systematic process to identify and discontinue medications in which in like some circumstances in which existing or potential harms outweigh the potential benefits within the context of an individual patient's care goals, or life expectancy or values and preferences. So when we talk about this deprescribing, there are some challenges. Like some patients are reluctant to change their medications. Fear of condition worsening, especially patients with chronic pain who are using opiates. Automatic refill of discontinued medications. Multiple prescribers with no coordinations. Lack of training or confidence, and this is related to the physicians, or fear of legal or clinical consequences. Another assessment tool is No Tears. It's a tool maybe used to review medications and help with a medication reconciliation. The 7 components of the No Tears tool are as follows. So the N stands for the need and indication. So we are trying to assess if the patient still needs each medications on the list, and is there an indication for this medication. O stands for open questions, like we can ask the patient about adherence, concerns, or if they notice any side effects for the medication. T, tests and monitoring. Our labs, like we order labs or clinical monitoring, like we should keep them up to date, like we should checking renal function regularly, monitor the INR closely, like with Comedine. E, evidence and guidelines. Like is the medication, when we talk about evidence and guidelines, we check if the medication is still supported by the current evidence and latest guidelines. A, adverse events, like if there is any side effects, interactions, or prescribing cascades. R, and stands for risk reduction or prevention, are like if preventive measures in place, like when we prescribe non-steroidal anti-inflammatory drugs, do we co-prescribe proton pump inhibitor as well? And with some medication, do we protect the bone and supplement with calcium and vitamin D? And the last one is simplification and switches. Can the regimen be simplified or switched to safer and easier alternatives? And that's it for today. Any questions? Thank you all.
Thank you, Dr. Marian, for that insightful discussion. If anyone has any questions, we'll hold them for the Q&A session later. Or do you want to do it now? Do you have any questions?
As you like, if anybody has a question, I'm ready to answer it.
Okay. Does anyone have any questions? Okay, so next, moving on to our next topic, research methodology. Dr. Malaz Idrees will guide us through the essential components of a research paper from the abstract to the discussion. Dr. Malaz?
Hello, everybody.
Hello. The floor is yours. Over to you.
All right, can you hear me okay?
Yes, we can.
All right, so I think Dr. Rana is supposed to start by discussing the abstract and basically the introduction. Then I'll carry on from the methodology.
Hello. Hi, can everyone hear me?
Yes, we
Yes.
can.
Is my voice clear? Hello, is my voice clear?
Yes, it is.
Okay, can you guys see my screen?
Yes, we can.
Okay, perfect. Right, hi everyone. I'm Dr. Rana. I'm a graduate from Sudan and currently I reside in Saudi Arabia. Today, me and my colleague, Dr. Malaz, are going to be presenting how to write a research paper or a manuscript. So this session, whether you're a new writer or you're a seasoned writer, it's going to be a brush up and you are going to be given basic info and logistical information about how to approach writing a research paper, starting with the abstract, going to the introduction, and then we'll follow it up with the discussion of and methods and results. So I hope this will be like a light and fluffy session for everyone to digest. And to start a research manuscript, basically, the first thing you want to look at is going to be the title. So the title is the first thing that is seen by journal editors before the abstract, and it's the first thing to grasp the attention of readers and researchers. So it's important that your title needs to be written correctly, briefly, and nicely. So what makes a good title? First, it has to be short, so a maximum of 15 words to 100 characters. And this is because longer titles are harder, and the longer titles will make it harder for everyone to fully grasp the context of your research. So it's always easy and important to make it short. A good title is a title that has keywords that feature the main rationale or objective of a research. And this is why this is important. This is important because it will make it easier for people who are looking through your article or searching for papers to find your article through these keywords. It will make it easier for discovering and hence make it easier for people if they want to cite your article. It's also important that the most important results and outcomes are reflected, meaning that you give the people the gist of this whole article that you're writing. And then it's best that you write the title last after you're done writing your whole manuscript. And this is because you might find that your conclusions and findings may alter your writing, your title. So by writing it last, you can just start with a working title. And as you go along and finish your manuscript, you can finalize your title for the better one or definitive one, as you may confer. You also need to avoid using abbreviations as much as you can and acronyms and jargons that are tough to understand or too complicated. Because again, people are searching for your research paper and it's easier to find research with simpler words and no acronyms or abbreviations. So that's the gist of how to write a title. Let's move to the next section of writing a research paper, and that would be the abstract. Now, the abstract, they say, a JAMR editor actually said, that the abstract is the single most important part of your manuscript, and that yet it's the most often poorly written. And you're probably wondering, how can we write an exquisite art abstract if that's the case? But it's also important to know what makes it bad. And some of the things that could make an abstract look bad is an abstract that is longer than the prescribed word count, which is almost around 250 words. You're making it longer, sometimes the journals wouldn't even accept your abstract because, again, as you write the abstract, it's based on the journal you're applying or submitting your manuscript to. So a long abstract, that's a problem. And not effectively stratified section-wise. You're not making it coherent for people to read and sectioning it according to the importance, which we are going to be speaking about soon enough. Essentially, copy-paste it from the main text. That's a big no-no. You shouldn't be copying from the main text, but rather you're writing something that would represent your main paper without really going into the details of it. It contains information not present in your paper. It's like false advertisement, and you don't want to do that. Citations included. Usually abstracts do not have citations. You leave that for the discussions and methods and the introduction. No effective take-home message. You should ask yourself, why are we reading what you are providing? You need to make sure that the objective of your paper is clearly stated in your abstract. And then again, written as an introduction or a conclusion of a paper. Again, the abstract is a concise writing, and it has to be something that gives you a bigger gist, like aside from the title of what your article or your manuscript is about. So how do we write an abstract? The first thing readers read, it's the first thing that readers read, and your paper is most likely judged by the abstract because people are always looking through things, and it's usually the only part available electronically, which is why keywords are also important. The keywords that you use throughout your article or your title are important because people will search for it, and in turn, they'll find it through your keywords. And you have to follow the journal guidelines, which is usually a word count. You could usually need a word count of 250 or 70 to 300 words. The abstract is usually structured or unstructured, and unstructured is basically one whole paragraph written in a stratified manner, and a structured abstract is basically something where you divide things based on the objectives, the methods, the results, and the conclusion into sections. But again, you keep it short, and then like around 250 words. And you need to write a well-rounded abstract. So you need to summarize the main points briefly and descriptively as much as you can. You include the background, the objectives, the study design, the primary results, and the principal conclusions. So you should essentially write your abstract by asking yourself three main questions. What is new in this study? What are you adding to the literature that is new to the world? And what does it add to the current literature? And what are the future perspectives? What are the angles that we can look at this abstract from? What things can we decide that we need to write more research paper on based on your paper? Or what can we approach eventually from your paper? So the introduction, which is gonna be the background in the abstract, should be around like a short sentence, one short sentence, briefly dragging the attention of the readers and just telling them briefly the background of why you decided to choose whatever research you chose. And then you have to put the objectives as an imperative style, which means that it has to be very direct and clear. So the objective, whether it's put into your abstract directly or indirectly, it needs to be clear. For example, to evaluate whether magnesium L-threonate supplements during USMLE preparation affects memory retention and learning. So that's a very clear objective. And we base, for example, the whole paper on this one objective and research question. Then you go to the methods and the results. So 2 to 4 sentences together. And the conclusion, 1 to 2 sentences together. And of course, you need to put emphasis on the methods, results, and the conclusion, because this is especially the conclusion, because this is usually where the eyes stray towards when looking through papers. So it's important to put more effort into writing more sentences into the methods and the conclusions. But again, it's a limited amount of sentences and a limited word count that you should keep in mind based on the journal's specific criteria. So it has to be written last, of course, after you're done with your whole text and you figured out the findings of your manuscript, you will end up writing it at the end. And it should not include excessive background information, like we said earlier, or citations or abbreviations, like example, etc. include, or acronym, like cystic fibrosis, CF, or IBS, or RHDs. And you should avoid a lack of rationale and meaningful data. So you have to be very clear with your abstract and your aims, and provide meaningful data. The results that you found in a clear and honest way. And you should not overstate your conclusion. So it has to be a clear conclusion without any repetitions. This is an example of an unstructured abstract. As you can see, they started the first sentence is just a summary of what they're researching, which is about reprogramming fibroblasts into induced cardiomyocytes. And they already know what has been accomplished in the previous research. But then again, they said that reprogramming them remains to be accomplished. So they're telling you their rationale, their goal of this research paper that they're writing through their abstract, okay? And then the next part is the method where, like I said, they usually take more sentences and write more in. You can see here, they wrote around like 3 sentences describing how they went through the process of their research, briefly, but very imperatively. And then they went to the conclusion. And although it's just 1 sentence, they made sure to signify and show you the implications of this research and how it's going to help or, put into perspective what people could do following this manuscript. So it's an attractive abstract, an unstructured attractive abstract. And then here we have a structured abstract where they put the objectives directly. They use the verb establish to describe what they want to do, and they to establish the challenges of Boston general practitioner encounters while treating patients with myelodysplastic syndrome. So they made sure to emphasize their objectives and make it clear on what they're looking for, or the main research rationale or question, so to speak, or hypotheses. And then they went on to the method, and although it's just 2 sentences, they made sure to clearly tell you exactly what kind of study design they used and how did they build around the study design and the sample size and all that in just 2 sentences, very clearly. And the results, of course, they started with telling you exactly what the outcome of their research was, so the challenges that they were looking into, and whether their research question or hypotheses was proven. And you can see they put it all in just 2 sentences. And finally, they focused on the conclusion, which is where the eyes stray towards usually when looking through papers or searching for papers online. So they put the conclusion that of the interpretation of their study and the importance of the study and what further research or action could be carried out after following up through the limitations of the research that they have. So this is a structured abstract, and like I said, it's just a couple of sentences, and you have to keep it very summarized and clear. Then we're going to move to the next section, which is going to be the introduction of the research. And this is where you start the storyline of the manuscript. You should always ask yourself, would this introduction be able to convince the readers? Will it highlight, like, because the introduction is the area where you highlight like the areas of the study, and you provide your rationale and the justifications as to why we're doing what we're doing in the research. So it's important to know if you're convincing people with your introduction. And again, it's about 10 to 15% of the total paper word count, usually 500 to 750 words. And it should not be written like a review. So you keep all your details, the context of it, and the comparisons to your discussion. Here, you just want to talk about your research question, your justifications, and the gaps and the significance of what you plan to do, but not in details. And it should be, you should always try to use or reference papers that are not as old. So you should, for instance, limit the age of a paper to 10 years, and always look for recent studies, because again, evidence-based medicine is important. You should strive to enlist the objectives in the last paragraph, and this is because it will attract readers and it will have a good impact on them usually when you're summing it up and giving them the objective in the end. And if you have 2 or more objectives, make sure you don't mix them together and write them in separate sentences. For instance, in the early example for the magnesium threonate supplementation, we want to see the performance. That's one objective. And then the other is, for example, the learning and the cognitive improvement, the USMLE performance, and then the learning and cognitive improvement. So these are 2 objectives that will be stated clearly in the end of the introduction. Now, the introduction has a structure. It's generally 3 to 4 paragraphs. And it's an inverted pyramid where we go from like a broad aspect of talking about a problem or a situation, and then we narrow it down to the rationale, which is basically what we plan to do about it and how we are going to get it done, or we got it done. So you start with the this is like how you write your paragraphs. So the first paragraph is basically just a general intro of what you're planning to do. Like, we extrapolate all the relevant and the current literature, and these are like the general information. We put it into a single or 2 or 3 sentences, and then we move on to the next paragraph, which is basically we look at what has not been answered or has conflicting data within the area of the study until now, the unknown or not done. And we move to the third paragraph, which is what has not been fully discussed and tackled within the existing literature, like the gaps in the literature. And then finally, we sum it up with the rationale, which is what we are planning to do. You could think of the introduction as if you are trying to convince someone about something you really need. So obviously, you're going to have to give them like a broad intro of what you want. And then you go into exactly why you think it should be given to you or take it, right? So instead of saying it through words, you're writing it into your paper. And eventually, you just give it to them, tell them that you want to do this to get what you want, right? So it's an art of persuasion if you think about it. Instead of speaking it, you're just writing it down. You could usually, sometimes we mix the third and the second and the third paragraphs together. So this is an example of how we can of an introduction to the earlier topic I mentioned, the magnesium threonate. So the first thing we ask ourselves is, what is the known general problem or the current situation? And here, magnesium is an essential mineral. It's best known for its role in bone, heart, CNS function. And then the mactane, or the magnesium threonate, is a formulation that crosses the blood-brain barrier and hence could have potential cognitive benefits. So this is like the general problem or the current situation of our research, that we're the introduction of our research. Okay, so we gave them a background, and then we went on to talk about the unknown and the gaps together. We were, despite its popularity, evidence for its effectiveness in young adults is limited. Furthermore, no studies have assessed its impact on USMLE performance. So we highlighted the gap in the performance and how it's there's limited studies or evidence on the effectiveness. And then finally, we put our rationale, which is what the hypothesis or question, or how we will answer them, the questions we have. So our question is to determine whether magnesium threonate improves memory retention and USMLE performance. We are going to be doing, or we conducted a randomized placebo-controlled trial of mactane supplementation. And hence, through writing our introduction in this style, where we spoke about the gaps, and then I mentioned what we're gonna do, or what we did actually to tackle this issue, we were able to tackle our objective, which is basically to determine if supplementation will improve the recall, learning speed, and the overall test performance. And then what will happen is that our findings in the end will help guide evidence-based cognitive enhancement strategies in USMLE preparation. So by writing, if I was able to just put these four paragraphs together into a Microsoft Word, this could be like an early on working in progress introduction, which I can build on and make it look better and more scientific, and use more active language than passive language. So this is basically how you could write an introduction. And as I said, it's an inverted pyramid. And then once you spoke about the like from broad aspect to a more narrowed, focused description of what you're studying, then you move on to the discussion, which is going to be an upright pyramid, the normal pyramid, where you go from what you found in your research to what you think you could compare it to, and so on. And Dr. Malaz will indulge you in this in the next coming slides. I hope what I just said and provided was beneficial. And if anyone has any questions, we can take them by the end of Malaz's this presentation. Thank you, everyone.
Hi again, everyone. Thank you, Dr. Rana, for providing us with this very comprehensive overview of the abstract and introduction section. So now I'll take it from here, and just let me share my screen. All right, so I'm hoping that you're able to clearly see my screen right now.
Yes, we can.
All right. So regarding the method section, just a second, please. So I think the method section is the most important section in the manuscript, because it contains information about how you conducted your research, and it helps others replicate your study. It basically gives a description about how the research was done, along with a justification of why that particular method was chosen among others. So in the method section, you should be able to answer 3 main questions: what was done, where it was done, and how it was done. So the method section is, it comprises the bulk of your papers, around 30 to 40% of the content, and it usually gets the most attention during the peer review process. Basically, peer reviewers care about the fact that you have followed a sound research methodology. And during peer review, any major mistake can subject your result to getting a major revision or sometimes getting rejected at the first time if it's a major mistake. So it's very important to structure a very like a well-rounded methodology and follow it throughout the research process. All right, so the method section covers 7 core parts, namely the study setting, study design, sample size and sampling technique, ethical approval, recruitment methods, experimental and interventional details, and statistical analysis. So let's start by talking about the study setting, and this is very straightforward, just basically where the study was conducted. It could be a clinical setting, like a healthcare facility, or community-based, like a neighborhood, for example. For the study design, you basically identify whether your study was a cross-sectional study, case control, interventional, so the type of the study. Also, in this part, you should ideally mention your sample size and how it was calculated. You should also describe the sampling technique used and give a rationale of why this specific technique was used instead of another one. For example, why it was more appropriate for you to use convenience sampling or simple random sampling. Regarding the ethical approval, you should be able to clearly identify the study approval body, whether it was an IRB or an ethical committee, and also you should mention that you have made a proper collection of informed consent from the participants. Regarding the recruitment method, you should clearly state the inclusion and exclusion criteria as they define the boundaries of your study population and ensure the validity and relevance of your findings. When choosing inclusion criteria, you should consider characteristics that are essential for answering your research question. This might be things like age ranges. For example, you're just going to include participants who are 18 years or above, or like let's say 40 years and above. Also, it might be diagnosis, timeframes, or types of intervention. So these criteria should align with your study objectives and help you identify participants who are most relevant to your research. For the exclusion criteria, they are used to remove individuals, on the other hand, that might introduce bias or confounding or even safety concerns to the study. It could include things like comorbid conditions, people who are taking another concurrent treatment, poor data quality, or high risk of like dropout or attrition. So in here, the goal is to create a study sample that is as homogeneous and reliable as possible without compromising generalizability. The 5th point is the experimental and intervention details. In this part, you should exhaustively describe each and every detail of all the experiments and interventions carried out in the study in order for the readers to be able to reproduce the study independently. The final part is the statistical analysis. And in this part, you should be able to mention all the statistical analysis carried out with the data which include things like descriptive statistics. It can be like percentages or frequencies, and inferential statistics like mean, mode, or p-values, confidence interval, and odds ratio. So these are the 7 core parts comprising the methods section. I'm going to use this sample of our paper, which was conducted about the impact of April 15 war on hemodialysis patients in Sudan. So in the first part, we started by the study design, which was a cross-sectional, multi-center health facility-based study. And then we mentioned the interval. After that, we moved on to the study setting. Then the study population, where we clearly stated our inclusion criteria. It was all patients who were receiving hemodialysis in renal dialysis centers in Sudan, and we excluded patients who were in a critical medical condition or those who were below 18. In the sample size and sampling part, we provided the formula with which we calculated the sample, and we provided also the response rate at the end, along with the sample size. All right, so I consider the instrument of measurement as the most important part of this section. And it really strengthens your paper if you go over in details in this particular part. So in here, we tried to give a brief introduction about the structure of the instrument. Then we gave a brief overview of each questionnaire or subsection that we included. And it's really important to provide information that this part or this instrument that you've used was validated, along with a citation for this. All right, so now let's move on to the results section. It's really important to report the results in a concise and an objective manner, meaning that at this point you don't need to interpret or discuss your results. Obviously, you're going to do that later in the discussion section. You should also be able to provide answers to the objectives or questions elicited in the introduction, because basically that's the whole point of conducting a research, because you're trying to, at every point, to answer your questions or your objectives. One of the most common mistakes is failing to provide adequate findings or reporting findings that are unrelated to the objectives of the study. Another important thing is that you can draft the results in a chronological order for a smooth and a logical flow. You can also break them down into subtitles for a better readability. So typically, the first paragraph should contain demographic data. The subsequent paragraphs should introduce the inferential analysis of the data based on the rationale and objectives of the study. Another thing is that the results should be written in a completely objective manner without providing any sort of interpretation. It should be written in the past tense. A quite common mistake is that people may often report the results or their findings in the present tense. The last point is that tables and figures are the go-to when you want to make heavy data easier to understand. So proper positioning and citation of the tables and figures within the main text is very critical for the flow of information and the quality of the manuscript. Also, one of the major mistakes to consider while preparing tables and figures is providing wrong interpretations of statistical results or missing essential details of the analyzed data. One should also avoid missing values in tables and should present measurement units in a clear manner. Basically, you're trying in here to be as meticulous as possible. An important point is that analysis of the data might yield myriads of findings. So the author should avoid attempting to report or discuss all these findings. You should just prioritize the most important findings and give them a context, basically. This is another sample from our study. In here, we tried to provide an objective finding without interpreting the finding. Also, we used p-values as an inferential statistic, and we used the past tense. It's also very important when preparing tables and figures to add like a very brief summary with the most important findings in each table or figure. All right, so now let's move on to the discussion. I think the main purpose of writing a discussion is to fill the gap that was identified in the introduction of the manuscript and to provide true interpretation of the results. So in the discussion, you need to comprehensively describe and the interpretation of your findings and then compare it with the available relevant literature. It's the part of the manuscript where you give your findings a context, and it gives you a very good opportunity to strengthen your paper. So basically, you'll be taking each finding and provide a comparison with the existing literature, and this comparison could be either concordant or discordant. For example, in here, in the first paragraph, our finding was concordant with the literature, and in the second paragraph, it was entirely different. So basically, that's how we reported and compared the findings to the literature. Another thing is that putting results in context helps you identify the strengths and weaknesses of your study, and it enables the readers to answer very important questions, which are what are the implications of the study? And the second question is how the study advanced the field further. How do you contribute to the existing body of literature? For example, in your study, you might have bridged a very important gap, but failed to report another, which is totally fine. This can be mentioned as a limitation or a recommendation for future research. All right, so now we're going to talk. I'm going to try to break down the general structure of the discussion section. The first paragraph is usually reserved for highlighting the key results of the study as brief as possible, and the authors should utilize this part to emphasize the originality and significance of the results in the field. The second paragraph should deal with the importance of your study in relationship to other studies available in the literature. The third one, or the subsequent paragraphs in general, they give your findings a context by describing the findings in comparison with other similar studies in the field and how the gap in knowledge has been filled. in the fourth paragraph, or like the subsequent paragraph, the authors need to highlight the strengths and limitation of the study. And this is actually very important. It can be, it might be viewed sometimes as a weakness, but if you write the limitation part in a smart way, it can actually strengthen your paper. The final paragraph is usually reserved for drawing the generalized conclusions. It's basically like a take-home message. So I'll just try to use our paper again as a sample. Basically, we started by talking about how important our study, that it's a pioneering study and it's one of the very few studies done in the field. You should be careful about, like, you want to state the novelty of your paper, but you should avoid words like, this is the first paper ever done, or so just try to be subtle in this part. Then lastly, we mentioned the limitations of the study. That's all. Thank you so much for listening.
Thank you, Dr. Malaz and Dr. Rana, for these clear and practical tips. That's a great resource for all of us working on manuscripts. Our next speaker, Dr. Sondos Yassir, will help us streamline our workflows. Dr. Sondos, we're eager to hear your insights.
Okay, hello, Sudan. Am I audible?
Yes, you are.
Okay, thank you so much. I'll start sharing the screen. I will just have to leave the meeting and re-enter again. Just 1 minute.
Okay, we'll be waiting for you.
Can you see my screen?
Yes.
Yeah, we can see your screen.
Okay. So, hello, my name is Sondos Yassir, and today we are going to learn how to organize our digital files through Google Drive or OneDrive. As you know, digital files organization has become an important part in our professional life. And today we will explore two of the most commonly used cloud storage solutions, Google Drive and Microsoft OneDrive, and how they integrate into our daily productivity tools like Gmail and Outlook. We will also cover their core features, differences, and tips on how to keep your digital life organized and efficient. So, why do you think digital file organization matters? First of all, it saves time and reduces stress. Before diving into the tools, let's reflect on why digital file organization is crucial in both academic and professional settings. Firstly, as I said, it saves our time. With well-labeled folders and files, you can find what you need instantly. Secondly, it reduces the digital clutter. Just like a messy disk slows you down, a cluttered drive or desktop can be overwhelming also. Thirdly, it improves collaboration, especially when you are working with others remotely. Everyone needs quick access to the right files. And finally, good file organization reduces the risk of losing important documents and overwriting valuable data. So, Google Drive and OneDrive, what are they? Okay, Google Drive is Google's cloud storage platform that allows you to store and share and collaborate on files. It's tightly integrated with Google Docs, Google Sheets, Google Slides, and also Gmail. On the other side, we have Microsoft OneDrive. It's a part of Microsoft 365 suite and integrates directly with tools like Word, Excel, PowerPoint, and Outlook. Both tools offer cloud storage, access from any device, and real-time collaboration features, but they each have unique strengths, which we will explore next. So, the storage and the accessibility. Here's a quick comparison in terms of the storage and how you can access your files. In Google Drive, it offers actually 15 gigabytes of free storage shared across Gmail, Google Photos, and Drive. In OneDrive, it offers only 5 gigabytes. Regarding the accessibility, in Google Drive, you can access Google Drive from web, from mobile, from desktop, as well as OneDrive. And also you can edit your files offline. So both of them, they have offline access, so you can view and edit selected files even without an internet connection. So the organization features. When it comes to staying organized, both platforms give you tools to structure your files. In Google Drive, you can use folders, color coding, and labels, and we will see that in a minute, to label and sort your files visually and logically. The powerful search function helps you to find files by type, by date, by the owner of the file, or even the content. OneDrive uses a more traditional folder. It supports files on demand, which is a feature that shows all your files, but only download them when you need them. Saving local storage, both platforms allow also renaming, starring, and tagging files, but Google Drive is often praised for its search intelligence. So we'll dive on the OneDrive files on demand feature. It enables users to view, search, and interact with files stored in OneDrive from within the File Explorer. For anyone who's using Windows, I think you will see that without downloading all the files to the device. So as you can see here, the downloaded file will be in green, and the files that are on the drive, you will see the cloud icon. The feature provides a seamless look and feel for both OneDrive and local files without taking up space on the local hard drive. So it's very useful if you don't have space in your computer or your device. And as shown in the following screenshot, files that haven't been downloaded have a cloud icon for their status. For those files that have been downloaded in your computer, the status shows a green check mark. So the collaboration tool. So now let's talk about the collaboration. Both Google Drive and OneDrive support real-time editing and commenting, which is a very important tool, especially if you are doing a teamwork like a research. With Google Drive, multiple people can edit a document at the same time using Google Docs, Sheets, Slides, and see changes as they happen. OneDrive offers similar features using the online version of Microsoft Word, Excel, PowerPoint, and these also support co-authoring and comment threads. And both platforms include version history, so if you want to get back to a previous version of your document, you can do that. This is especially helpful in groups projects, as I said, and the research work and business environment. So let's talk about the Outlook integration with OneDrive. As you know, the Outlook is it's an email app. Previously, it's called Hotmail, I think. So OneDrive's integration with Outlook is a major benefit for Microsoft users. You can attach large files directly from OneDrive without sending bulky attachment. Outlook can automatically save email attachment to OneDrive for easy access and cloud backup. You can also share files using secure links. This feature, it's only for OneDrive. Google Drive doesn't have this feature, like to send someone password or to set the file or the folder for a limited time. This is only in OneDrive. And keep everything connected to your Microsoft Calendar and Teams. This level of integration improves workflow efficiency, especially if you manage a lot of documents and emails daily. So now let's talk about the Google Drive integration with Gmail. Similarly, Google Drive is integrated into the Gmail experience. You can insert Drive's files directly into emails or send Drive links with permission options, and we will see that in a second. When someone sends you actually an attachment in Gmail, you can save it directly to Drive in one click. Google Calendar and Google Meet also allow file sharing and linking to Drive content, making collaboration across meetings and emails very easy. This setup works actually it works well if your institution or workplace is centered around Google Workspace. So it depends on your institution if they are using Microsoft or they are using Google Workspace. So which one should you choose? So how do you decide which one is right for you? So you can go with Google Drive if you already use Gmail, Docs, and other Google tools, and if you prefer a clean, simple interface. Also, you can use Google Drive if you work with teams that collaborate in Google Sheets or Docs frequently. You can choose OneDrive if you use Outlook, Word, Excel regularly. Your organization, actually, it works with Microsoft 365 based system. Or if you need tight integration with Teams or SharePoint, ultimately, your choice depends on your ecosystem, as I said. Okay, so now let's talk about some tips for organizing our files. So no matter which platform you use, there are universal best practices for staying organized. First of all, use a consistent folder naming system. For example, by the project, by the year, or by the topic itself. Avoid creating duplicate files with vague name. Also, archive files you don't use often, because that will reduce the clutter. Back up your important document regularly, even if they are not in the cloud. Also use the search tools and filters and tags to quickly locate your files and to not waste any time digging for your files, actually. So file organization is just like digital hygiene. It keeps your work clean and it keeps your work efficient. So before watching the video, I'm going to show you how we can use OneDrive and how we can use Google Drive. So here, I logged in with my Google account, and this is my drive. So if I want to, I don't know how to delete that. Just wait a second. Yes, this is the eraser. Okay, so if I want to upload a new file or folder or anything, I will click here, new, and then file upload or folder. I will choose this one. For example, I will upload this photo here. Okay, now it's saved on the Google Drive. And as you can see here, I have 15 gigabyte to use in Google Drive. Now I want to organize, for example, I want a new folder from here, new folder, and I will name it, for example, photos. Okay. Now I have a new folder. I will put this photo here. So let's see how can we organize our folders. I can click here on the three dots, and then I will click organize. So you can organize it with colors, with tags, or with stars. I will choose organizing with colors, for example, red. Okay. And then I'm going to upload another photo, for example, this one. And I'm going to make a new folder and I'm going to name it, for example, June photos. Okay. And then here, three dots, organize, red. So now if I want to search for the photos folders, I will just select the red color and all my files would be in red. So let's talk about how can we share the files and the permissions. For example, now I have this folder. I will click here and then share. I have two options, share and copy link. I can copy the link directly or I can click here and it will open this window. Here I can choose whether it's restricted or it is for anyone with the link can access the folder. So if I select it restricted, I should add people. I will add them by their email. For example, okay, this is an email. And I can send a message for the person. And here I can select whether he or she is an editor, commenter, or viewer. Viewer can only see the folder, commenter can comment on the file or the folder, and editor can edit actually the file or the folder. So if I choose anyone with the link, so now anyone that has the link can have access to your folder, but you can select whether he is a viewer, commenter, or editor. Okay, and as you can see here, I can use Google Docs, Google Sheets, Google Slides, Google Forms directly and save them in the drive, and anyone in your team or in your group can work with you at the same time. So now let's have a quick look in OneDrive. So this is OneDrive. I signed in with my Hotmail. And in Google Drive, I signed in with my Gmail. Okay. Skip the weird email. Okay. So here, if I want to upload the file or folder, I will click here. The same thing. I will choose this photo. As you can see here, I have 5 GB in my cloud. Now I will click on my files. So this is my new photo, okay? Let's create a folder. Okay, I will put this one here. Okay, I will click the 3 dots. And we can manage the access. There is a little bit difference here. So I will click share. The same, you can share with people with emails, and you can send a link for a group or your family and so on. So I will click start sharing. Here you can edit. Sorry, you can select like the person. Is he going to edit or only to view? Here I can copy the link. And I can send it directly to the email. Okay, so as you can see here, in OneDrive, we use Word document, Excel, PowerPoint, OneNote, and Excel survey. So it's different from the Google Drive, which we use docs, sheets, and slides. But if we, for example, here, now I have a document, for example, hello, and I want to save it, I can save it as a Word document from here, Microsoft Word. And it will work in OneDrive and on Microsoft systems. So it's okay, and I can download it as a PDF or whatsoever. So this is just like a general idea on how you can use the drives. I have a video, just 1 second. Can you hear the video? Or there is a
No.
problem?
No, we cannot. I think it's
Okay.
paused.
Yeah, I think there's a problem with the permission, no problem. I will send you the link on the chat so you can watch it later. Okay. So the summary, both tools are very powerful, and the Outlook pairs best with OneDrive, as we said, and Gmail works well with Google Drive. And the key is choosing the one that matches your workflow. This is the most important point. So do you have any questions or thoughts?
Thank you, Dr. Sondos. We
Welcome.
covered so much today. Before we wrap up, does anyone have questions for our speakers?
I think Yassir has a question. He said, "Is OneDrive paid?" Actually, you have only 5 GB for free, and then yeah, it's paid actually. But you can find offers, like yearly offers and so on. But only 5 GB is free.
Any other questions? Okay, if not, thank you all for your time and contributions. Have a wonderful evening.
Thank you so much, Dr. Saudad, and thank you all the presenters. Great job. Before we end, any
Thank you,
update?
Doctor. We appreciate it.
You're welcome. Any updates, any projects, any new ideas or questions about the program or any other questions?
Hello, Dr. Nader.
Hello, Dr. Osman, go ahead.
Yes, I just have an research. We're a team. We've been working on research for talking about CKD for about a year now. We've finished it and we've done the questionnaire. We've done it in Sudan, in multicentric areas, in many cities in Sudan. And we've actually finished the manuscript. Many of our team members are currently enrolled into your program. And we would have wanted to ask you if we could send you the abstract of our research. It's 2 researches. I could give you the title of them right now. And I would like to share my abstract or the abstract of both of the researches with you. So we just want to know if you have any other insights or any other ideas to improve them.
Sounds good. So I'll be happy to look at them. And also I'll ask Dr. Ahmed Dawanur. He is a nephrologist, so he will have much better input for you guys. And if there is any suggestions, it's gonna be coming to your way, on your way.
Okay. Thank you, Doctor.
Thank you. I appreciate it. Anyone else? If none, then I'd like to thank you again.
Thank you, Doctor.
Go ahead. Dr. Malaz, go ahead.
Yes, thank you, Dr. Nader. I have a bit irrelevant question, but how do you advise us to proceed in the light of the ongoing uncertainty and with the travel ban proclamation?
Where are you located now?
Yes, I'm located in Qatar at the moment.
All right. So what I would suggest is to continue your preparations. If you want to do the steps, if you want to do any other activities to help your application, and think of applying next year. Hopefully, the organizations here, the American Medical Association, and also others will help move the exceptions as far as medical personnel and providers for training. So we don't know, things might change. So what I suggest is do your best. It's going to help you whether you are taking the steps in your career, if you are still in Qatar, or if you plan to move to another area like UK or something. So knowledge-wise will help you. Being certified from the US, you have the certificate that also will help you in your career. So that's in case still there is a problem with the visa. But I hope things will change, and at least there will be some exceptions. So good luck.
Yes, thank you so much, Dr. Nader. We hope for the best, and we'll just keep working on the residency application for the next cycle.
Yes. Sounds good. I wish you all the best. And anyone else? If not, I'd like to thank all the presenters, the team from today's meeting, and also all who attended today's meeting, and those who will watch the recording in the future. Have a wonderful day or night. See you next week. Assalamu alaikum. Thank you once again.